Hi everybody, this is Dr. A. In this serology video, we're going to look at testing for specific diseases. So let's first go over the principles of testing in serology. So there are several types of tests that we can do. One is based on the agglutination principle. So agglutination methods are based on the clumping of cells or the clumping of antigen-coded latex particles. They are often graded as 0, 1 plus, 2 plus, 3 plus, or positive negative reactions. So up here is an example of latex-coated particles, and there's agglutination in this one. So that would be positive. There's no agglutination in that one. That would be negative. An immunofluorescent assay. Direct assays will use a fluorescent antibody to detect an antigen in the sample. And indirect assays will use a fluorescent antibody to detect another antibody in the patient's serum. So either way you're using fluorescence. So fluorescence is a molecule is fluorescent if it can emit light after you shine light on it. So just think of your glow-in-the-dark stuff. If you shine a light on it, it kind of charges it. You turn the light off, it glows. Well, that's fluorescence, and you can tag those molecules on antibodies and then detect the presence of those antibodies if they reacted with an antigen or with another antibody that it was trying to detect. Chemiluminescence is another type of immunoassay. So chemiluminescent labels can be attached to an antigen or an antibody. And those chemiluminescent labels are being used to detect proteins, viruses, oligonucleotides, which are small sections of DNA or RNA, and nucleic acid sequences, again, sequences of DNA or RNA. And again, it's usually an antibody or an antigen that's tagged with a molecule. And a chemiluminescent molecule is a molecule that can emit light from a chemical reaction. And so the illustration of that is your glow-in-the-dark sticks, where you have to activate them and break the little ampule inside, and the chemicals react with each other and produce light. So that can happen. You can have the chemical that's tagged on the antibody or antigen, and then it's the other chemical that's needed to react with it. And then once those are mixed, if the first chemical that was tagged on the antibody, if the antibody was there or the antigen was there, got captured and it's part of the assay, then it would create light, and so then it can be detected. And then in an enzyme immunoassay, it uses an enzyme molecule, can be tagged onto specific antibodies, and then they react with a substrate to produce a color change. So enzymes are always going to be color change reactions as it reacts with the substrate it's made to react with. And so this will include, for example, the enzyme-linked immunosorbent assay, which is the ELISA test, which is well known. So all other than the agglutination, all of these are antigen-antibody type of reactions with a detection molecule that's tagged on an antibody or sometimes an antigen. So the direct and indirect sandwich techniques for an enzyme immunoassay. So the enzyme immunoassay will have color changes. So if the target antigen is present in a specimen, it will form a stable complex with the antibody bound to the matrix. And then unbound specimen is removed by washing, and then a second antibody specific for the antigen is added. So basically what they're saying is we're starting with the matrix, which is represented by the black line, with antibodies tagged on it. So that's part of your reagents, part of your test. And then you add your sample, and if the sample contains this green molecule, this green antigen that we are looking for, that molecule, the antigen, will tag on this capture antibody here. And then you have a wash step that removes anything that has not been bound to this capture antibody. And then the second antibody that's tagged with the enzyme that can cause a color change that we would detect can only bind if the antigen was captured by the first antibody. And so if there was no antigen, if this molecule was not present in the sample, then this has nothing to bind on, and then you have another wash step and it would be removed and you would have no signal. Okay, so in the direct method, The second antibody is what is conjugated to the enzyme. So this is a direct sandwich immunoassay represented here. There is also an indirect method in which it's a second non-conjugated antibody is added and washed, and then the third antibody is the one that has the enzyme, and it's specific for the second antibody. And so that third antibody is conjugated to the enzyme, and that's directed against the Fc portion or the constant portion of that unlabeled second antibody. And so this direct method is really good for detecting antigens. The indirect method is good for detecting antibodies too. So you have the matrix, you have the capture antibody, you have the antigen, and then you have the antibody, hopefully in the patient's serum, that is going to be complement to that antigen. And the third antibody that's reacting with the second antibody is the one that's labeled, and that would cause a color change. And so there's going to be wash steps in between this stuff here. Now, realistically, you could also use this to detect an antigen. So you could use this to detect an antigen, or you can use this to detect an antibody. Either way, for sure, the detectable antibody is part of the reagent, and the capture antibody is part of the reagent. So the majority of your immunology tests are going to be done on serum, and testing for antibody levels, we do antibody titers. And so those are serial dilutions. So there are dilutions that are done in series. So if you use a 1/2 dilution, you have your first well is usually undiluted, the second well is 1/2, and the third well is a 1/2 of a 1/2, so that's a 1/4. And then the next well is going to be a 1/8, then a 1/16, 1/32, 1/64, and so on. If you do a 1/10 dilution, first well is undiluted, second well is a 1/10, third well is a 1/100, 1/1000, and it keeps going. And so the way you determine the titer is you have the reaction, the enzyme reaction, immunoassay reaction, and obviously it should be at least positive in the undiluted. And then as long as you have a positive reaction, you dilute it further and further, and the last dilution where you still have a positive reaction is going to be your titer for that antibody. And so it helps you to see how much of the antibody was present. Of course, the more you can dilute it and still get a reaction, the more of the antibody was present in the first place. So let's talk about immunologic and serologic testing for specific bacterial and viral diseases. So we're going to start with Lyme. So Lyme is a tick fever that's caused by a spirochete that's named Borrelia burgdorferi. So spirochetes are bacteria. This is the spirochete right here, right down here. You see it's a spiral shape. Okay, and we want to use serology testing because these little boogers are really hard to culture. They like to burrow into cells and stuff, and it's just really hard to retrieve it. It is possible, though, to detect them now using PCR testing. So it looks for the genetic components of this organism, and so you can detect them directly, but just with PCR, not with culturing. The serology test on sensitive in the early phase of infection. It's harder to detect the IgM to the spirochete, but in 2 to 4 weeks post the initial infection, 70 to 80% of the cases are going to be seropositive for IgG against Borrelia burgdorferi. The antibodies can persist for years post-infection and treatment and will consist of cryoglobulin antibodies, immune complexes, anti-Borrelia antibodies, and anticardiolipin antibodies. And there's a lot of people with Lyme disease that have had Lyme disease that have symptoms that linger for years and years and years that can eventually have autoimmune issues, and so there's some tie into these anticardiolipin antibodies and other immune complexes and stuff. The diagnosis of Lyme disease is often based on symptomology, this typical bullseye rash, and this is in patients that have been exposed to ticks, so maybe they were out in the woods or out for a hike or out hunting, and they did so in an endemic area, in an area that has Lyme disease, that has a lot of the ticks that carry Lyme disease. But the serology testing by immunofluorescent assay or ELISA can be done if the rash is not present to detect and diagnose Lyme disease. Next is syphilis. It's a sexually transmitted infection that's caused by another spirochete. This one's named Treponema pallidum, so this is also a bacteria. And it also likes to hide, and it's really hard to culture, so we tend to test for antibodies instead. It has 3 stages: primary syphilis, secondary syphilis, and tertiary syphilis, and it has latent periods in between where there won't be any symptoms and everything's kind of dormant. If it is untreated in the primary stage, it will progress to the secondary stage within 2 to 8 weeks, and this is the most contagious stage, and it can last up to a year, in which, of course, the infection can easily be spread. And then the third stage can occur 3 to 10 years after infection, and it tends to affect the brain, so it can spread to the brain and cause mental status changes and all kinds of problems. The serology testing will include testing for treponemal antibodies and non-treponemal antibodies, and those are called reagent antibodies. So the RPR agglutination test will detect non-treponemal antibodies. It's the rapid plasma reagent test, or RPR test. And that first slide where I had the agglutination assay, it was positive and negative, is very typical of that RPR test. And the FTA antibodies, so this is the fluorescent treponemal antibodies, and the MHATP test, so they can detect treponemal antibodies. So the first test, FTA-ABS, is fluorescent treponemal antibody absorption, and the second one is microhemagglutination treponema pallidum. Those are both tests that are specific for treponemal antibodies. So this one is a little bit more non-specific. So if it's a good screening test, but then if the RPR is positive, then you need to go ahead and send it for one of these to see if there is indeed treponemal antibodies present. And then if the treponemal antibodies are present, then the patient does have syphilis. Next, we have the acquired immunodeficiency syndrome, or AIDS. It is caused predominantly by HIV. And HIV will infect the CD4 positive T lymphocytes. Those are your T lymphocytes that are your T helper cells. And then as the CD4 count decreases, the AIDS worsens, and this is because those T helper cells coordinate the response of the immune system, and they're really critical to a proper immune system response. So as those CD4 count cells decreases, there's less and less T helper cells, there's a decline in immune function, and you'll see more and more opportunistic infections. So opportunistic infections are infections that are caused by bacteria or fungi that are normally harmless and that wouldn't hurt somebody with, it wouldn't cause an infection to somebody that has a normally functioning immune system. We can detect HIV-1, so anti-HIV-1 antibodies will take time to appear. It takes 6 to 12 weeks. So often if there's a suspected exposure to an HIV individuals, it is good to test at the time of exposure, suspected exposure, but if that test is negative, it really needs to be repeated at 3 months and 6 months interval to make sure that it is indeed negative, because it is very possible that there was exposure, but it's not detectable for several months. The standard method for initial detection is the enzyme immunoassay for anti-HIV-1. The standard method for confirmation testing of HIV is going to be the Western blot assay. So if the initial screening is positive for anti-HIV-1, then it should be confirmed with the Western blot. But now there's also a 4th generation testing that can replace this Western blot, and this is the HIV-1 P24 antigen test and HIV-1 and HIV-2 viral nucleic acid testing. So this is where they're looking for the genetic material of the viruses directly. This point-of-care testing available, but it's less sensitive. It does require confirmation. It is based on the initial detection, the enzyme immunoassay for anti-HIV-1. It's in those little cassette type tests that are very similar to pregnancy tests. It's a positive, negative, can be done at home with a blood drop or two, and just have to know that if that is comes back positive and needs to be confirmed, and if it's negative, it may need to be retested in 6 to 12 week window. And then you can also do viral load monitoring, so we can detect and monitor the HIV RNA in plasma, and this has become preferred over the CD4 cell counts, which used to be done to see at which stage the patient was and if they were entering the stage of the AIDS syndrome. So next we have infectious mono. That is a viral infection. It is caused by the Epstein-Barr virus. It is the most ubiquitous human virus. 95% of the world's population has been exposed to Epstein-Barr virus. It can infect anyone, but will manifest itself more in adolescents and young adults. And it lasts about a month with extreme fatigue, sore throat, swollen lymph nodes, and fever. And it is spread via oral pharyngeal secretions. So it's called a kissing disease, but it could also be spread by sharing a drink and drinking from the same drink as somebody else. 90% of the adult population has antibodies to the virus. They are either heterophile antibodies or Epstein-Barr virus antibodies. And you can do a rapid test for mono, either a cassette-based, line, no line type of test, or a latex agglutination test. Sometimes those may not be positive early on. It may take a little bit for them to turn positive. The viral hepatitis, we have viral infection of the liver. I do have more videos that go a little bit more in depth on this, but the gist of it is you have hepatitis A virus, which is transmitted via the fecal oral route. So this is usually dirty hands handling food or contaminated food. And you can test for anti-HIV IgM or IgG antibodies to detect if they have hepatitis A virus infection. And hepatitis B virus and hepatitis C viruses are both transmitted by blood and sexual contact. And the tests for these are, there are several numerous ones. There's a hepatitis B surface antigen, the hepatitis B envelope antigen, the anti-hepatitis B core antibody, the anti-hepatitis B envelope antibody, the anti-hepatitis B surface antigen antibody, and you can also do hepatitis B viral DNA by PCR, and you can also detect anti-hepatitis C virus antibody. And last, let's look at the autoimmune disorders. So in autoimmune disorders, the body attacks itself. There are more than 40 different ones. It predominantly affects women, but men can get it too. And having one autoimmune disease makes one more likely to get another. It tends to be an overreaction of the immune system, also tied to some of the hypersensitivities we discussed in the previous video. So let's go over some of the basic ones. We have rheumatoid arthritis. It attacks joints and joint tissues. The rheumatoid factor can be present. It is identified in the serum or the synovial fluid in many, but not all, RA patients. And it's the antibody to the Fc portion of IgG. The rapid test for the rheumatoid factor is usually a latex agglutination assay. In multiple sclerosis, there is a degradation of the myelin sheath of nerve, so that is the protection around your nerves that keeps the signals from getting short-circuited. Basically the same reason you have coating around wires and electricity, the same job of myelin sheath. Multiple sclerosis is usually diagnosed with medical imaging and spinal fluid test that rule out other diseases. You can detect IgG in the spinal fluid, but it's not, diagnostic of just MS. There are other conditions that can raise the spinal fluid IgG levels. Type 1 diabetes, you have the destruction of the beta cells of the pancreas, and it is diagnosed by chemistry testing. So you would see high glucose levels, ketones would be present, you will do ABG and see metabolic acidosis. And so those are type 1 diabetes type of results. You can check for those autoantibodies to the B cells also to diagnose, but usually we use all the chemistry testing to diagnose type 1 diabetes. And then we have systemic lupus erythematosus, also known as lupus. It is an acute and chronic inflammation with circulating immune complexes. So it tends to be a mix between a type 2 and a type 3 hypersensitivity reaction. The lupus antibodies are usually to nuclear components, so components of the nucleus, but also the cell surface and some of the cytoplasmic proteins. So they can have antibodies to white cells, red cells, platelets, neurons, etc. The rapid slide test for the anti-nucleoprotein is a latex agglutination for ANA, anti-nuclear antibodies. And this is positive in systemic lupus erythematosus, but also in rheumatoid arthritis, scleroderma, and Turgeon syndromes. ANAs are anti-nuclear antibodies, and they are found in 95% of lupus patients, but it is also found in rheumatoid arthritis and old people. What I want you to think about is normally what happens is in a properly functioning body with a properly functioning immune system, there are cells that are turned over and regenerated all the time, and what happens is they are destroyed and dissolved, and all the components are recycled or broken down, etc. But if the cells are, they are ruptured or destroyed, and then the components aren't cleared, then you have components of the nucleus, of what's in the plasma, the cell wall, and all of that are floating around, and then they get detected as foreign antigens because they normally should have been cleared. And so that's why it can happen also in older people, because their immune system will start to decline. And so the process is called autophagy, and it's normal. But that process can go awry, and that's when you see, the process of autoimmune diseases like lupus and RA, but you can also see it in aging. And the test is an indirect immunofluorescent test, and it uses fluorescent anti-nuclear antibodies, and then they can bind and create certain patterns depending on what they bind to. And then the last two are celiac disease and ulcerative colitis. So in celiac disease, the antibodies to gluten can cause the atrophy of the villi in the small intestine, and then that can cause absorption issues, can cause anemia, low protein levels in the blood. It can cause just a host of problems, and the treatment for that is the removal of the gluten from the diet, and then the villi can usually be restored mostly, and you can look for several of those antibodies to gluten, like the anti-gliadin, anti-transglutaminase antibodies, and etc. And ulcerative colitis is an inflammation of the colon. We don't really have a blood test for that one. It's usually diagnosed with a colonoscopy, where they go in and see what's going on in the colon, because there's a lot of inflammation. Of course, there's inflammation in all the autoimmune disorders. You would see increased C-reactive protein levels and high SED rates, but those are very nonspecific, so it doesn't really tell you much other than there's inflammation going on. So anyway, so that wraps up for specific disease testing and serology, and I hope that was helpful to you as a good review of serology.